Hey everyone, my name's Mariah and I'm going to be presenting on methicillin-resistant Staphylococcus aureus, better known as MRSA. MRSA is caused by a drug-resistant strain of the gram-positive bacteria Staphylococcus aureus. Not all strains of Staphylococcus aureus are drug-resistant, but MRSA is resistant to many different antibiotics. MRSA infections began to emerge in the 1960s after the introduction of methicillin, which is a semi-synthetic penicillin. Initially, MRSA infections were only seen in healthcare settings, which are known as HA or healthcare associated, but they can now be found in communities all over the world called community associated or CA. Staphylococcus aureus can cause a wide range of infections, usually involving the skin, soft tissues, blood, bones, joints, or areas where devices are inserted into the body, like catheters and prosthetics, as well as pneumonia, bacteremia, and sepsis. MRSA can result in death. A lot of people think about central line infections and catheters when they think about MRSA infections. And just a fun fact, the picture in the bottom right, I had a MRSA infection a few years ago that looked just like that, except mine was about 3 times bigger, and it was in my leg and not my foot. So I have a personal interest in MRSA. In the top left, you can see a picture of the staph bacteria. According to the CDC, MRSA is considered to be a serious threat. They estimate that there are over 80,000 severe infections and 11,000 deaths per year from MRSA, based on 2011 data. And they also think there are much higher numbers of less severe infections. According to the Center for Disease Dynamics, Economics, and Policy, MRSA is the leading cause of mortality due to antibiotic-resistant infections in the United States. Risk factors for MRSA. Although anyone can get MRSA, you're at higher risk if you visit, work, or live in crowded places, have frequent skin-to-skin contact, and share objects or equipment. I got my MRSA infection from the gym at the apartment complex I was living at the time. Individuals who are at higher risk for MRSA are athletes, children in daycare, students, and those living in dorm or barracks accommodations. Individuals in inpatient care settings or recent hospital exposure, long-term antibiotic use, weakened immune system, having open or exposed wounds, and poor hygiene or unsanitary conditions are all risk factors for getting MRSA. My surveillance questions. Number 1, does the incidence rate of MRSA differ between race, ethnicity, and/or gender? In order to properly survey, mitigate, and control a health outcome, it is necessary to understand how it affects different populations. Number 2, has the incidence rate of MRSA been changing over time? Since MRSA is considered to be a serious concern that can have deadly consequences, it is important to know if the rates of infection are increasing or decreasing. And number 3, has the mortality rate of MRSA changed? Since MRSA has the highest mortality rate of any antibiotic-resistant bacteria, it is necessary to know if the rate of death is changing. Data sources and collection. The CDC is the primary U.S. agency for surveillance and data collection about MRSA, specifically through their Emerging Infections Program, or EIP, which is a population-based surveillance system that includes approximately 15.9 million persons represented in 10 different states. The EIP population is roughly representative of the U.S. population. There's also the National Healthcare Safety Network, which is also involved in MRSA surveillance. Does the incidence of MRSA differ between race, ethnicity, and/or gender? According to data from the Emerging Infections Program, the number of cases of MRSA per 100,000 population in 2016 was 19.5 for white, 30.3 for Black, and 5.4 for other. Although similar disparities have been seen every year since the CDC's EIP began storing data about MRSA in 2005, there are several studies that have suggested that adjusting for other factors cancels out the racial disparity seen in the CDC's incidence rates. Several studies have found that males are more likely to have a MRSA infection, carry the bacteria, or get a blood infection from MRSA than are women. Male gender rates were found in one study to be 1.5 times higher than women in the United States. Another study found that the incidence rate for males was 63.5%. Has the incidence rate of MRSA been changing over time? According to the CDC, the national adjusted incidence rates of MRSA infections in 2005 were 37.5 per 100,000. In 2010 were 26.5, and in 2016 were 20.2 per 100,000, which seems to be decreasing over time. A national survey of inpatients from different authors in 2006 found that the overall MRSA prevalence rate was 46.3 per 100,000 inpatients, which is significantly higher than the rates seen in the CDC's data. Have the mortality rates of MRSA been changing? According to the CDC, the national adjusted mortality rates from MRSA death rates per 100,000 persons in 2005 for community-associated MRSA infections were 0.24, for healthcare-associated were 6.39, and the mortality rates per 100,000 in 2013 for community-associated were 0.54, and for healthcare-associated were 2.58. So the healthcare-associated MRSA mortality rates have been decreasing, but the community-associated MRSA infections have been increasing. So if the overall incidence rate for MRSA has been decreasing, why has the mortality rate for community-associated MRSA been increasing? Limitations. The CDC only includes persons from 10 states for their EIP surveillance system, which is supposed to be representative of the entire US population, but may not be sufficiently accurate to represent the entire population. Similarly, the Humphreys, Fitzpatrick, and Harvey authors that found men had MRSA rates that were 1.5 times higher than women only used data from 9 states. Similarly, the results might not be representative of the entire country. There are many studies that contradict the rates found by the CDC, and one study found that the difference in incidence between races was eliminated after adjusting for socioeconomic factors, since MRSA is considered to be more common in lower SES areas. In conclusion, there are thousands of MRSA infections and related deaths every year. While the CDC has provided evidence to suggest that the incidence rate of MRSA in the US is decreasing, the mortality rate of community-associated MRSA infections is rising. Some studies have found that the actual rates of MRSA might be significantly higher than those determined by the CDC. Other studies claim that there are no differences in rates between ethnicities, but they can be adjusted out by controlling for various factors like SES. So the next steps, since MRSA is still the deadliest resistant bacteria in the US, more research needs to be done to either support or oppose the CDC's findings about the rates of MRSA infections in the United States. The CDC should evaluate the accuracy of the EIP and other MRSA surveillance programs to determine if the current methods are still appropriate and accurate. It is also necessary to evaluate if the EIP population is truly representative of the entire US population. The CDC should also adjust for other potential confounding factors when determining disparities among race, ethnicities, and others. And my references. Thanks, everyone.